Uh, First of all, let me give the conflict of interest. Today's topic is, it's a sponsored session by Apple. In school, my English teacher used to tell me that you should learn one word every day, which I never obeyed or followed. But this topic at least gave me that I remembered my English teacher, because Malestorm. How many of you don't know the meaning of that?
I didn't know realize our topic today.
I didn't know that. So that's from the first slide itself. I would learn one new word. It's actually a whirlpool, a severe whirlpool. So a metabolic whirlpool. The understanding the link between type 2 diabetes and cardiovascular risk. So the conflict of interest of today's session is that this session is organized by Abbott Healthcare Private Limited in association with JPEF to facilitate knowledge sharing and the medical fraternity and all the usual things that they have mentioned. But one thing, let me tell you from the positive side, which I have found in this presentation which they provided, is that there is no direct reference to any of their product. It's just knowledge sharing. That is one good thing I appreciate about the company, though it's a sponsor session. So I'll be talking about this metabolic malestorm or the whirlpool. The diabetes is an epidemic in India. That's something that we know. And actually there is nothing new here. We are actually trying to revise what all things we know and also just take it as a flashback of all the data and whatever things, then get into the conclusion of just revise the guideline part of it. So we know that by the OGTT criteria, there's around 101 million people with diabetes, and overall diabetes prevalence ranges from 4.8% in UP to 26.4% in Goa, and Kerala and Tamil Nadu reaching almost up to Goa. So the prevalence is quite high, 24%, 25% or 20%. It's actually 1 in 4th or 1 in 5th, which is almost like everybody should be a diabetologist for the future. So the high prevalence translates to a population of risk of cardiovascular disease and other complications, both macrovascular and microvascular complications, which already been covered in the previous saying that previous talk. Also it was said that the so many beneficial drugs, which I will also be touching about. The pathophysiology we know, again the ominous octet, which was given by the Alfonso. About the decreased insulin, decreasing incretin effect, increased lipolysis, increased glucose absorption, all leading to the hyperglycemia part, along with the increased glucagon secretion, increased hepatic gluconeogenesis, neurotransmitter difference, dysfunction. So what are the challenges in management of diabetes in India? On an average, newly diagnosed diabetic patients is said to have 1.7 major atherosclerotic ASCVD risk factors that are in play in them. So already there, that's why previously there was a terminology that said that diabetes itself should be considered a CAD equivalent, coronary equivalent. Because there are so many risk factors already present in them that the risk of ASCVD is around 1.7 times, that's almost double from the general population. And when you look at the major risk factors that are on play in a diabetic population, the low HDL value is there in 55.6%, higher age 50%, hypertension in 40%, smoking, tobacco use 21%, and chronic kidney disease. That's very surprising that stage 3B chronic kidney disease at the time of diagnosis is seen in 11.2% of patients. That's a very high percentage, stage 3B. That's a very high percentage of a higher degree of CKD that's present even at diagnosis when we do the albumin, creatinine and all those evaluations. Another thing about Southeast Asian diabetes or the Indian diabetic is that we are, as a bunch or as a genetically predisposed group, we are more predisposed to complications. Why? For those reasons, like we have a thin fat phenotype. We know the YY hypothesis, which actually says that though we have a low BMI, most of our fat gets accumulated intra-abdominally, that we get increased predisposition for cardiovascular disease. Then there is data which says that we have an earlier onset of diabetes and also a delayed diagnosis of diabetes. That's why most of the guidelines says that though internationally we should screen people at this age, probably we may screen Indians at 5 years or 10 years down earlier. We may even start statin a few years earlier. That's what almost all the Indian guidelines suggest, though we don't have clear-cut data to suggest that. But because of these risk factors, we are actually extrapolating the data and saying that we should start earlier. So there's a delayed diagnosis, there's a weight which is high compared to the obesity parameters, and there's a data which says that we tend to have more of microvascular and macrovascular complications. The risk of hypoglycemia is more probably because of the thin, obese, that kind of factors. And most of our patients are uncontrolled with an A1C of more than 7 and with increased comorbidities, we should think, or we should understand that with all these factors, Indians tend to have 2.35-fold higher risk of coronary artery disease. And so when you think of a diabetic who is walking into our OPD, we should also understand that the cardiovascular risk burden of these patients is much, much higher. How does this cardiorenal metabolic interaction happen in type 2 diabetes? See, we know that it's related. It's something that we know. Diabetes, chronic kidney disease, heart failure, coronary, all these things are related. But how? The hyperglycemia, which produces insulin resistance, which tend to produce oxidative stress, alter substrate metabolism, advanced glycosylation end products, albuminuria, and also it produces neurohormonal and inflammatory response, which together lead to increased cardiac congestion and cardiac output, which again forms cardiac fiber, which lead to cardiac fibrogenesis and heart failure, and also it leads to renal congestion and abdominal renal functions and renal fibrogenesis, and that's why then it progresses to chronic kidney disease. Then further, this heart failure or the cardiac and renal fibrogenesis actually reverses back into the pathogenesis of neurohormonal and inflammatory response and increase its severity, and finally it leads to fluid overload kind of scenario, which in turn again increases the cardiac failure and heart and chronic kidney disease. So finally it becomes a serpentarian path that self-propagates itself to a severe condition. So cardiovascular complication of diabetes, when you look at it, it is said that around 65% of death are due to CV disease in a diabetic population. Coronary artery disease risk increases by 2 to 4-fold, stroke risk increases by 2 to 4-fold, and heart failure risk increases by 2 to 5-fold. Heart failure, surprisingly, most of us don't recognize that. Sometimes it just goes unrecognized because the cardiologists also may not take it into account on those patients who are admitted with cardiac failure. But it is said that first manifestation of type 2 diabetes related cardiac disease, CV disease, when you look at it, heart failure, peripheral artery disease and heart failure tops the first two positions. It's not myocardial infarction or stroke. So myocardial infarction and stroke continue to be chosen as primary outcomes for major type 2 diabetes trials and MACE endpoints, but we should understand that heart failure and PAD are more common than these events. CV mortality in type 2 diabetes, this data which looked into 1,53,000 patients of newly diagnosed type 2 diabetes and was followed up for around 10 years, the effect on heart failure development and prognosis compared with other CVD and renal parameters, it was seen that heart failure development at any year since type 2 diabetes diagnosis was associated with highest 5-year absolute and relative risk of death and decreasing lifespan in the next 5 years. Patients with diabetes have a higher incidence rate of heart failure and diabetes, and this accelerates time to first CV event. You can see that heart failure with diabetes, it's actually a difficult combination and can lead to the increased mortality. Diabetic heart failure, it's actually double trouble because it's said that 2 to 5-fold increased risk of heart failure is there in patients with type 2 diabetes, 60 to 80% greater probability of CV death and all-cause mortality in those with type 2 diabetes and established heart failure. Diabetes is a major risk factor for development of heart failure, and heart failure is one of the most common first morbidity of type 2 diabetes. You can see here that participants from Framingham Heart Study and Framingham Offspring group, you can see that you can see that the risk provided by diabetes is quite high, much higher than even LVH and valvular heart disease, and it's almost even higher than angina pectoris. So it's almost up to myocardial infarction and equally compounded by hypertension. So when you look at it, you have to actually look at it that diabetes, hypertension as a combined thing, which is almost there in most of our diabetic population, how it could add up to. And also the multinational registry, including 7,72,000 patients with diabetes without history of CV disease or CKD, actually found that the first comorbidity that is associated with diabetes is heart failure in 24% and CKD in 36%. So heart failure is a very important part and should be there in the background of your mind when you're looking at our elderly diabetic population. The role of inflammation in type 2 diabetes and CVD risk, subclinical systemic inflammation is often present in diabetic patients. Systemic inflammation has also been implicated in pathophysiology of atherosclerosis. Epidemiological studies found a correlation between inflammatory markers and CV endpoints. Several clinical trials found reducing subclinical inflammation led to beneficial outcomes, and current literature indicates strong relationship between inflammation and clinical endpoints in diabetes. What are factors responsible for development of CVD in diabetes? See, we know a lot of factors like glycemic variability and cardiovascular disease. The higher the glycemic variability, it has been shown that it increases the risk not just of cardiovascular mortality, also of neuropathy, retinopathy, nephropathy. So glycemic variability, not just the high sugars. High sugars are definitely bad, but also the how it is maintained. If it's having a high glycemic variability, it tends to increase the inflammatory markers and other glycosylation end products which I mentioned earlier, and actually can lead to increased CVD deaths. So lipid abnormalities, there are a lot of people who ask saying that how do you say that LDL is causal? There are definite evidence data from observational epidemiological studies, Mendelian randomization and genetic analysis, randomized clinical trials and animal experiments, which shows that LDL definitely is the causal factor for ASCVD events, and LDL target should be a primary goal in our treatment aspect. So from that perspective, what does ADA say about it? ADA says that any diabetic between the age of 40 to 75 at higher cardiovascular risk, including those with more than one ASCVD risk factors, we should aim something of a LDL cholesterol reduction. Whatever may be the LDL, we should aim at something of LDL cholesterol reduction of more than 50%, or at least to a LDL level of less than 70 milligram per day. Secondary prevention aspect, in a patient with diabetes and ASCVD, treatment with high intensity statin is recommended to reduce the target to less than 50, reduce the level to more than 50% of what we chose from the baseline, with the LDL cholesterol goal of less than 55. And addition of ezetimibe or PCSK9 inhibitors may be considered if the patient is not tolerating the highest dose of statins, or if the patient doesn't reach that target despite on maximum statin. So what is the LDL cholesterol targets by cardiovascular risk categories in patients with diabetes as per the ESC 2023 guideline? Again, they say the same thing. A patient with very high risk should be on a LDL cholesterol level less than 55. A high risk he should be on a LDL cholesterol level less than 70, and a moderate risk should be LDL cholesterol less than 100. So less than 100 should be a standard in all diabetic patients, provided they are ready to take it and they are ready to continue with it. That's one problem which I see commonly in practice, is that the moment they do LDL cholesterol level, they usually go for total cholesterol only. So when they do the total cholesterol level and see that the value is less than 200, they say that the disease is cured. That's what happens. So hypertension in diabetes and severe, that's again another important scenario, because that's something that commonly coexists in most of our diabetic patients. So functional changes occurring in diabetes and hypertensive conditions significantly alter the hemodynamic stress on the heart and other organs, and the epidemiological studies have elucidated the role of impaired microcirculation in CVD. See here, you can see, I'm not going to the details of the slide, but you can see that this part you concentrate when you see that the presence of diabetes and hypertension together lead to thickening of basal membrane, reduced lumen diameter and smaller capillary area, and that is a definite risk factor for macrovascular events. So what about screening and diagnosis of hypertension in patients with diabetes as per the ESC 2023 guideline? So there we say that the BP of 130 to 139 systolic and diastolic less 85 to 90 should be considered a high normal BP, and hypertension is something where any of the BP is above 140 or 90. And then once you confirm it, you should be very aggressive in managing it to a standard level. Overview of role of anti-diabetic agents in therapy of CVD disease risk and diabetic population. This is something that we know because it has been, all of us have been bombarded with information in this aspects, and almost every day, today itself, most of the talks will be covering few of these aspects in every topic. So the ASC guideline 2023 says that a person with high ASCVD risk or already having ASCVD event should have a GLP-1 receptor agonist or SGLT2 in his treatment armamentarium. A person with a heart failure should be having SGLT2 inhibitor, and stroke TIA, we should prefer GLP-1 receptor agonist or pioglitazone in the management. And CKD definitely should be SGLT2 inhibitor for the GLP-1 receptor agonist. And from the data which was presented today initially, or also from the previous speaker, you will see that when you actually look into the criteria, even almost all diabetic patients maybe above the age of 40 would fall into this criteria. And what they say is that only those patients who are out of this criteria, who doesn't have any of these risk factors which are mentioned here in the stars, they are those people whom we should direct the glucose-centric perspective. So all the other population, that the massive chunk of population of diabetic patients visiting your OPD, we should definitely control the diabetes, but we should be looking at it from a different perspective of cardio-renal centric diabetes management. So we should be thinking of not just diabetes control, also from the cardio-renal perspective of how to improve that, not just the sugar control. The same way the ADA is also almost imaging the same criteria and guidelines, where the ASCVD risk suggests the inclusion of GLP-1 receptor agonists with proven cardiovascular benefit, cardiac failure, SGLT2 inhibitor, and CKD, again SGLT2 inhibitor. So management of CVD, ESC 2023 guidelines, the clinical approach and key recommendation, what they say is that in a patient with CVD with diabetes, you should go for GLP-1 receptor agonist followed by SGLT2 inhibitor, and if there is a heart failure, definitely again SGLT2 inhibitor followed by GLP-1 receptor agonist. And if there is a CKD, then again SGLT2 inhibitor, and they have also suggested pinavalin. So timeline of published diabetes CVOT trials, you can see that they have already, the previous speaker mentioned a lot of trials in dapagliflozin, but again, not just dapagliflozin, almost all of them, GLP-1 receptor agonist, DPP-4 inhibitor, SGLT2 inhibitor, all of them have a lot of CV outcome trials, and we know from the multiple trials that there are a lot of effects which are class effects of that one particular group, and certain things specifically are implicated or beneficial effects are implicated to some certain drugs. So coming to summary of benefits in the diabetes CVOTs in CRM axis, the CV benefits, heart failure, we know that SGLT2 inhibitors and GLP-1 receptor agonists are beneficial. The 3-point MACE benefit has been seen with EMPA, Lira, semaglutide, canagliflozin, albiglutide, dulaglutide, sotagliflozin, embiglenatide. Metabolic benefits, all glucose lowering drugs, improved A1C levels, renal benefits, all SGLT2 inhibitors except sotagliflozin and dulaglutide has beneficial effect. Albuminuria, all SGLT2 inhibitor except sotagliflozin has effect. So saving lives, agents proven to save lives in patients with type 2 diabetes are EMPA, Lira, oral sema, all produces reduction in all-cause mortality and CV death. And also, I think, so finally the way the science is progressing, that what I feel is that finally what they would say is, if you really want to live, exercise well, if possible don't eat anything, and take a statin and SGLT2 inhibitor. That's what things are going into. Yeah, so summarizing, the treatment decision has become more patient-centric with number of factors into play. Treatment goals and plans should be created with patients based on individual preferences, values, comorbidities, impact on therapy and weight, hypoglycemia, which can help in better compliance and outcome. In this patient-centric care, incretin-based therapy, GLP-1 receptor agonists and DPP-4 inhibitors provides a robust choice. Thank you very much.
Thank you for the wonderful talk.